So this is certainly a different talk than the last two that we heard, but was a question that was asked earlier. The question is auto-transplant dead, I think, in the era of all of these new therapies that we're talking about. Again, same disclosure slide as before. So I think we need to review the two pivotal studies establishing auto-transplant for diffuse large B-cell lymphoma. First, the PARMA study in the pre-rituximab era. And just to remind everyone, in this study, patients who had relapsed or refractory large cell lymphoma received 2 cycles of DHAP chemotherapy, and then responding patients were then responding patients were then randomized to either receive more cycles of DHAP with or without radiation, or an auto-transplant with or without radiation. There were about 79 patients out of a total of 215 that did not have a sufficient response to DHAP chemotherapy. In terms of predicting, in terms of the patients who were treated, about a quarter of patients had relapsed after a complete response, 34% of patients had a PR, and 41% of patients had no response or had progressive disease to their upfront chemotherapy. In terms of response to DHAP, patients who had relapse disease were much more likely to respond to DHAP at a rate of 64% compared to patients who had refractory disease. Only 21% of those patients responded. And for that group in total, even patients who went to transplant, the 5-year overall survival was only 11%. Of note, all the patients who were randomized to auto-transplant had a CR to first line of therapy. This is a study that established auto-transplant as a standard of care for the treatment of chemosensitive relapse refractory diffuse large B-cell lymphoma with a 5-year event-free survival rate of 46% and a 5-year overall survival rate of 53%. And then that compared favorably to the ongoing chemotherapy arm, which had a 5-year event-free survival of 12% and a 5-year overall survival of 32%. Among patients who relapsed in this ongoing chemotherapy arm, only 53% had less than a PR to salvage chemotherapy, and 18 went on to get an auto-transplant, 16 of whom died as a result of progressive disease. These are just the curves showing the event-free survival and overall survival for the transplant arm versus the conventional treatment arms, showing the benefit of transplant in this group. And then the bottom curves are separating out the patients who were early relapsers, meaning within 12 months of initiation of frontline chemotherapy, versus late relapsers, which relapsed more than 12 months after the initiation of frontline chemotherapy. And you can see that there was an improvement in outcomes for patients who were late relapsers as opposed to early relapsers. So what did we learn from PARMA? We learned that relapse disease does much better rather than refractory disease, and in particular late relapsers, more than 12 months from their diagnosis, do much better than early relapsers. We learned that transplant does not benefit patients with the disease that's refractory to second-line therapy. That's 16 of 18 patients who went on to get an auto-transplant after progressing through DHAP and getting subsequent third-line salvage chemotherapy. And then in the pre-rituximab era, autologous stem cell transplant seems to cure about 50% of patients with chemosensitive disease. Then going to the Rituxan era, we have the CORAL study, which took patients with relapsed refractory diffuse large B-cell lymphoma, 62% of whom had received prior Rituxan, and randomized them to either RICE or RDHAP salvage chemotherapy. And then all responders went on to get an auto-transplant with or without Rituxan maintenance. The take-home of this was that RICE and RDHAP were equivalent as salvage regimens, and patients who went on to get an auto-transplant had a 3-year event-free survival of 53%, so somewhat similar to what we saw on the PARMA study. Interestingly, just like on the PARMA study, early relapsers and patients who had and now adding in patients who had a prior Rituxan, did worse than patients who were late relapsers or who had not had prior Rituxan. So just, again, just the curves to show that there was no difference between RICE or RDHAP as a salvage regimen. And then this curve on the bottom suggests that, that patients who had a PR to salvage chemotherapy did just as well as patients who had a CR. But this study was done in the era of CAT scan restaging, not PET scan restaging. So what did we learn from CORAL? We learned that rice is equivalent to RDHAP as a salvage regimen. We confirmed that early relapse after first-line treatment, as well as now added prior rituximab therapy, resulted in worse outcomes. This group on a whole only had a 3-year event-free survival of 23%, and that's because many of those patients did not respond sufficiently to salvage chemotherapy to then go on to receive an auto transplant. Of the group that went on to receive an auto transplant, their 3-year event-free survival was slightly better at 39%. And it would appear that a PR to salvage predicts for good outcomes with auto transplant, but as a caveat that this was done in the era of CT scans and not PET CT scan restaging. And in the PET era, we have several retrospective series from single institutions that suggest that Deauville 4 partial responses do predict for inferior outcomes with auto transplant. So this is the slide. I'm not sure if it depicts any, but it does look better there. Okay. So I think that from these studies and from our progress in understanding lymphoma and prognosis, we can identify a number of different subsets of sort of higher risk diffuse large B-cell lymphoma patients that may or may not do as well with this salvage chemotherapy and auto transplant approach. So we've already talked about patients who have an early relapse within 12 months of diagnosis. We've touched upon the patients who are primary refractory, meaning that they have a stable disease or PD to their first line of chemotherapy. We also talked about patients who are refractory to their second line and go on to get a third line salvage. Only about 39% of them will respond to third line salvage. We now understand the prognostic impact of double protein overexpressing lymphomas that overexpress MYC and BCL2, as well as double hit lymphomas that have translocations involving MYC and most often BCL2. And this is a high-risk group of patients for whom salvaging with chemo and an auto doesn't seem to produce the outcomes that we see with standard diffuse large B-cell lymphoma. Transformed indolent non-Hodgkin lymphoma also is a group of patients that don't seem to do as well. Yes, the patients who get to an auto transplant may have a good 4-year event-free survival, but most of the patients do not respond to salvage chemotherapy, and in that group, the 4-year event-free survival is only 27%. And then primary mediastinal large B-cell lymphoma, when the vast majority of patients will respond to upfront chemo, but patients who don't respond to upfront chemo or who relapse early after upfront chemo are very, very difficult to salvage. Only about 25% of them will respond to next line chemotherapy. Those that do and go on to an auto seem to do okay, but again, only a quarter of them would fit that category. So go back to the slide that I presented earlier, which is what is the efficacy of anti-CD19 CAR T-cell therapies in relapse refractory diffuse large B-cell lymphoma, and we'll go back to this durable remission duration rate of about 40%. And I'll call attention to the fact that on ZUMA-1, all of these patients had chemo-refractory disease, so they had stable disease or progressive disease through their last line of chemotherapy, or they relapsed within a year of auto transplant. So this is a group of patients that would not be eligible. This is a 40% long-term remission duration in a group of patients that would not have been eligible for auto transplant. On each of these studies, a lot of these high-risk groups that I outlined earlier were looked at in terms of their whether they predicted for better or worse outcomes following CAR T-cell therapy. And this is from the ZUMA-1 study. So patients who were refractory to second-line therapy, had primary refractory disease, had a high IPI. All of these patients did just as well with CAR T-cell therapy than patients who had better risk disease. This is from the Juliet study, and you can see that patients who were refractory to last line of therapy, patients who had a high IPI, patients who had double or triple hit lymphomas seemed to respond just as well as patients who didn't meet those characteristics. And then this is from the Transcend study of lysocell, and again you can see that patients with double and triple hit lymphomas, double overexpressor lymphomas, primary refractory lymphomas, refractory to their last line of chemo, and high IPI lymphomas all ended up doing just as well as patients who had better risk disease. So I think we could add another column to this table that shows a 40% long-term remission duration in each one of these categories. So the question then becomes, what is the optimal CAR T-cell timing? Should it always be in the third line, as the FDA label indicates? So for patients who are either transplant ineligible or relapsed after transplant, or should it be moved up as second line in specific subgroups of interest? And the question, I think that really begs the question is, does it matter? Will CAR T-cells be more effective if you use them earlier? So should you give the patient the benefit of the doubt, give them second-line chemo, and only if they don't respond, give them CAR T-cell therapies? Or do you lose something because CAR T-cells become less effective in that third-line setting? And so this is data that Fred Locke presented at ASCO last year from the ZUMA-1 study that looked at number of prior lines of therapy and some measures of response, as well as CAR T-cell pharmacokinetics, and the pretreatment CAR T-cell health. The health of the product. So patients who had fewer lines of therapy had a quicker doubling time of their CAR T cells in manufacturing, and had a higher ratio of naive and central memory T cells compared to effector memory and effector T cells, which, if you remember from my last talk, the group at Penn had showed was correlated with better response in a group of patients with CLL. The patients who had fewer prior lines of therapy also had improved responses, with 91% of patients and 94% of patients responding with one to two or three prior lines of therapy versus 80% of patients responding with 4, and only 38% of patients responding with 5 or more prior lines of therapy. And patients who had fewer prior lines of therapy also had improved CAR T-cell expansion compared to patients who were heavily pretreated. So there are, right now there's one open and ongoing randomized trial to test this hypothesis that CAR T-cells may be a better standard of care for patients with high-risk patients with relapse refractory diffuse large B-cell lymphoma in the second line. But each of the companies, both Novartis and Juno, plan a similar study. This study, this is the ZUMA-7 study from Kite and Gilead, where they take relapse refractory diffuse large B-cell lymphoma patients. The total is going to be 350 patients. These are high-risk patients as defined by having had a relapse within 12 months of initial diagnosis of their diffuse large B-cell lymphoma or high-grade B-cell lymphoma. And they're going to be randomized in a 1-to-1 ratio to either upfront second-line axi-cell treatment versus standard of care, where patients will get 2 to 3 cycles of investigator choice salvage chemotherapy, followed by a restaging. That restaging will fall at the same time as restaging from CAR T-cell therapy, which, I have to say anecdotally, some of my patients who have been randomized to CAR T-cells in this setting find out that they're in a complete remission before they would even go in for their transplant, which is an interesting point of reference. Patients who have a CR or PR to salvage chemotherapy in the standard of care arm will then go on to have high-dose chemotherapy and an auto-transplant, and then the non-responders will come off of this study, and those patients would be eligible for commercial CAR T-cell studies, commercial CAR T-cell therapy. The primary endpoint of the study is event-free survival, and there are a slew of secondary endpoints, including other measures of efficacy as well as safety, but also patient-reported outcomes, because I think that may be an important benchmark on a study like this. Some of the other studies that are upcoming with the other companies will differ a little bit in terms of whether patients with a PR would go on to auto-transplant, or whether, as I told you, in the PET era, a PR may not be predictive of good outcomes with auto-transplant, so those patients may fall into this non-responder arm. And then and whether or not they allow crossover to CAR T-cell therapy. But I think from a study like this, we will learn that in the selected high-risk group of patients where we think that CAR T-cells have a longer durable response remission duration, whether those patients will do better than standard of care, A, but it will also establish whether the outcomes are going to be better in an earlier line of therapy to then prompt us to think about whether this is actually a better standard of care for all comers with relapsed refractory diffuse large B-cell lymphoma. So in conclusion, CAR T-cell therapy is a new standard of care for diffuse large B-cell lymphoma in the third-line setting and beyond. It maintains its activity in certain high-risk subgroups for which salvage chemo and an auto-transplant seem to be less effective. The follow-up is still short, but the durable remissions are achieved in about 40% of patients, which, again, we're comparing historical controls, but seems to be better than salvage chemo and an auto in these groups. There's reason to believe that CAR T-cell therapy could be more effective in earlier lines of therapy, and the magnitude of that increase is unknown, so we should hopefully get some answers from these studies, but will it be over 50%, and will this be something that we might think about giving to all-comer relapse refractory diffuse large B-cell lymphoma patients, and those answers will come from the randomized trials of CAR versus standard of care in high-risk patients. So we'll answer whether CAR is better than standard of care for these groups, and then whether it's better enough in the second line to maybe replace auto-transplant. So I don't think you got an answer about whether auto-transplant is dead, but at least maybe you understand the data that we need to get to that, to be able to answer that question. Okay, that's it.